Cool. So yeah, the first topic that we're going through to kind of clarify is the psychological contributing factors relating to specific phobia. So we're looking at precipitation by classical conditioning and perpetuation by operant conditioning, because those were the main ones that that needed to be clarified. So the first one is called precipitation by classical conditioning. This basically means like, how do phobias develop in the first place? So when we say precipitation, precipitation refers to development. So how does a phobia actually develop? How is a phobia actually established? That is the idea behind precipitation by classical conditioning. So we know that phobias develop or are classically conditioned because there's a repeated association between something that shouldn't normally cause a fear response, something that would normally cause a neutral response, and there's a repeated association between that neutral thing and something that would usually naturally cause some kind of a fear response, like a loud noise would always make a baby feel scared and make a baby cry. Okay, so when you've got a repeated association between these two events, that is between the NS and the UCS, eventually it leads the NS to no longer be a neutral stimulus that leads to no response, but to actually transform into what we call a conditioned stimulus. And remember, we said that the word conditioned stimulus is the same as the word phobic stimulus, okay? The phobic stimulus is the conditioned stimulus. It is the thing, the object or the event or the situation that leads to the actual fear response, or leads to the actual phobia response there. So that is what phobic stimulus is, okay? The phobic stimulus is the conditioned stimulus. And so for us to move from this stage of just seeing something as neutral, seeing something as causing no response, to moving to a stage where the white rat now actually causes a fear response, is the idea of precipitation by classical conditioning. The way that a phobia develops through the process of classical conditioning, through the repeated association between the neutral stimulus and the unconditioned stimulus, to eventually transform that neutral stimulus into a conditioned stimulus. And obviously, now that this is not a neutral stimulus, this white rat, which is the conditioned stimulus, which is the phobic stimulus, is now going to lead to a conditioned fear response. And this fear response is what we call as the phobia, or is what we call as the phobia fear response, okay, that we see in people who have specific phobia. So that's basically just showing you how specific phobias develop through classical conditioning principles. And if you're ever given an example or a case study or a scenario and you're asked to explain how precipitation by classical conditioning contributed to the development of the phobia, you should be able to use those classical conditioning principles to obviously explain that there was a repeated association between the phobic stimulus and between something else that would naturally cause that response. Okay, so remember when we did those examples when we were studying for the outcome 2 SAC for unit 3, when we were actually doing classical conditioning, we went through some examples where there were kind of phobia related examples. Like for example, a girl who goes to the nurse and gets her injections every year. Each time she gets her injections, they're quite painful, and over time she starts to develop a fear of the doctor. Okay, and so what has happened is that the actual unconditioned stimulus in that scenario is the pain from the injection. That would cause fear in any person. And the actual neutral stimulus is the doctor, because the doctor should never cause a fear response. But because the doctor continues to come to her year after year and give her the injection, eventually that doctor goes from becoming a neutral stimulus who produces no response to transforming into a conditioned stimulus. So now every time the girl sees the doctor, she's scared of the doctor, or she has a phobia of going to the doctors, even though her actual root phobia wasn't because of the doctor, it was because of the actual injection. So she's kind of transferred that fear response to another stimulus, and that stimulus is the phobic stimulus. Okay, so the little Albert experiment was a clear example or application of the idea of precipitation by classical conditioning, and that's why we've got his picture, the little Albert diagram picture here again. Alrighty, so that's precipitation by classical conditioning. Now the contrast to that is perpetuation by operant conditioning. So perpetuation by operant conditioning means, okay, we know that phobias develop through classical conditioning. How are phobias then maintained? Okay, phobias are maintained through operant conditioning. So the word perpetuation means maintenance. Okay, how are phobias maintained, or how are phobias modified? Because we can actually maintain phobias through operant conditioning, and we can also modify phobias through classical conditioning. What that means is that if I've got a phobia of seagulls, I always use this example, I don't know why. If I've got a phobia of seagulls, operant conditioning, that is negative reinforcement, can help me to maintain my specific phobia of seagulls and never really ever get over that phobia. If I'm a parent and I'm trying to, encourage my child to get over the phobia that they have of maybe clowns, I can use positive reinforcement to modify. Okay, modify means to change that phobia that they have. So every time my child comes with me what kind of example can I use? Every time my child sits through a cartoon that involves clowns or something like that, and they're not scared and they don't show kind of a fear response, or they actually, muster up that bravery and that courage to do that, I might give them some kind of a positive reinforcement, like, okay, here, you get an extra serving of ice cream, or, you did really well, let's go to the playground, or something like that. So depending on whether we're using negative reinforcement or positive reinforcement, that is what we call as perpetuation by operant conditioning, the ability to either maintain or to modify the classically conditioned specific phobia. Okay, so that's basically what perpetuation is about. Perpetuation is how do we, once the phobia is actually developed, how do we either maintain that phobia or how do we modify the phobia? The main way that phobias are maintained is through a process known as negative reinforcement, which is basically connected to the idea of avoidance behavior. Remember we said people who have specific phobias, they don't want to confront their phobic stimulus. If I'm scared of seagulls and my family is going to St Kilda Beach, I don't want to go with them because obviously I'm scared. I don't want to encounter and confront that phobic stimulus. So rather than going with them, I just make up an excuse that, I've got a lot of work, I've got a lot of assignments coming up, and I just stay at home. And in doing that, I actually get to avoid the seagulls. And by avoiding them, it gives me a sense of relief, which increases the future likelihood that I will again, the next time someone calls me to go to the beach, I will again say, no, I don't want to come to the beach, or I have other work to do, to again get that relief and get that comforting feeling. So that's how we maintain phobias. How we modify phobias is, like I said before, if I go with my family to St Kilda Beach and I actually decide, okay, you know what, I'm going to actually just try this. I'm going to confront my phobia. I'm actually going to go with them to the beach. And then my family's like so happy. So they buy me, I don't know, the latest tablet or the latest iPhone, or I don't know, whatever, something that would make an actual grown person happy. So essentially they get me something that I've been really wanting to get for a long time or something like that. That's positive reinforcement. So that might actually change my attitude towards the phobia and make me like closer to confronting it the next time as well. Obviously, positive reinforcements don't work really well when you've got adult phobia patients because it's a lot more entrenched in their minds that they have this phobia. They might have had it from a very young age. It's easier to use positive reinforcement to modify phobias in children compared to adults. Okay, adults are a little bit more not smarter, but I would say it's like phobias are more traumatic for some adults because they've lived with it for a longer period of time. And just getting a simple reward or positive reinforcement sometimes isn't worth it compared to the kind of trauma you have to go in terms of confronting that actual phobic stimulus. Okay, but again, that's what perpetuation is, either the maintenance or modification of a specific phobia through operant conditioning principles. Usually we're talking about reinforcement here, so either positive or negative reinforcement. If it's about the avoidance behavior, it's always the negative reinforcement that's involved there. Okay, if it's about giving a reward for someone stepping up and trying to overcome their phobia, then you would give them a positive reinforcement. So depending on what the patient is doing, whether they're stepping up to overcome the phobia, that'll be positive reinforcement. If they are avoiding that phobia and avoiding that negative stimulus there and avoiding that confrontation, that would be negative reinforcement. Okay, so then I think there was one more slide for this thing that just summarized it. So yeah, this is just, specific phobias are established or developed or precipitated through classical conditioning. So it's really important that you're familiar with these words, because in a question, whether it's in a SAC or whether it's in an exam situation, VCA always tend to use, you know, terminology that is specific to the study design. Okay, so they won't ask you something like outline how phobias are developed through classical conditioning. Rather, they would ask you something like outline how a specific phobia is precipitated by classical conditioning, or outline the process of precipitation by classical conditioning with reference to specific phobias. So if you're reading through a question and you can't unpack or you can't determine what the word precipitated or precipitation means, it's kind of your bad luck, because VCA expects you to know the definitions of these words and to know what these words mean. Remember, any word that's in your study design as a key knowledge dot point, you must know the definition of that. You can't get into the exam and see the word cognitive bias and not know what a cognitive bias is, because that's a word that's actually in the study design. So it's important that we are familiar with these keywords there. Okay, perpetuation means maintenance. So perpetuation is about how we maintain specific phobias or modify specific phobias through the principles of operant conditioning. So in many ways, this is a Unit 4 topic, but this is one of the topics that actually shows us the intersection or the relationship between Unit 3 and Unit 4, because we're taking our learning theories of classical and operant conditioning that we learned about in Unit 3, and we're combining and we're talking about them in relation to specific phobia, which is a topic that we learned about in Unit 4. And a lot of the time, we do need to understand that in exams, in your SACs, it's different, because in our SACs, we only do SACs according to the outcome. We don't mix outcomes together. So in the exam, though, you could have a question that starts off talking about a Unit 4 topic, and by part B or part C or part D of that question, you're talking about Unit 4, and then you're going back to a Unit 3 topic. Okay, VCA like to mix up the different outcomes and different unit topics together in different questions. And this is an example of a topic where it's very easy for them to take something from Unit 3 and combine it with a topic you've learned about in Unit 4. Okay, and wherever possible, we do need to try to make links to topics between Unit 3 and Unit 4. Okay, so that is basically the psychological contributing factors that we had to go through. Now let me check the chat box and see what else we have. Psychological interventions for specific phobia. Yes, I'll go through that. And then distinguishing between stress, anxiety, and phobia. Yeah, so that one is a few slides back, so I'll probably cover that one first. That was right at the beginning. Okay, yeah. So when we're talking about differentiating between stress, anxiety, and a specific phobia, there are certain keywords that you do need to remember to get the full mark. Now, when we're talking about stress and anxiety in general, these are just like the definition for stress is the same definition you would use from chapter 3, from Unit 3 of your book or your PowerPoint. So that's fine. Anxiety is basically this idea that the main keyword there, and I think we had the definition of anxiety somewhere here. Hold on. Oh, yeah, here we go. So anxiety is a state of physiological arousal. And the main kind of keyword there that you need to know is that it's this feeling that something bad is going to happen, okay? That something is wrong or that something bad will happen. And that's the main way we differentiate. Can't even underline properly on this thing. Okay, that's the main way we actually differentiate between stress and anxiety, okay? Stress is when you feel like you can't cope with the circumstances around you. Anxiety is often brought on by stress, but then anxiety is like this feeling that, you know, something's going to go wrong or something bad is going to happen. So that's the main difference between the two. Obviously, both stress and anxiety are states of physiological arousal, which means that they are accompanied by feelings of, increased heart rate, feelings of like sweaty palms, feelings of erratic breathing patterns and all that kind of stuff. So it leads to some kind of effect on your body and the way that your body functions and the way that your body operates. So that's basically what it is. So with the definition of anxiety, the main keyword we're looking for is that it's a feeling that something is wrong or that something unpleasant is going to happen, okay? And sometimes anxiety can be unfounded. So sometimes people are anxious over things that actually might not realistically happen. Now, the main difference between normal stress and anxiety, which we looked at on the previous slide, and specific phobia, stress and anxiety, is that the specific phobia, the kind of stress and anxiety that people with specific phobias experience is going to lead them to some level of impairment. It's going to lead to some level of dysfunction. And regardless of what case study you get in Unit 4, whether it's about a person with specific phobia, whether it's about a person who's got an actual mental health issue, if the question asks you, is this person experiencing a mental disorder, justify your response. The main things you're looking for in that case study is, number one, is that person able to function normally in life? That is, are they still able to go to school or work? Are they still interacting with their family and friends? Are they still doing the things that they love? Okay, if you've got a case study about a guy who usually goes and plays soccer with his friends every week, and in the case study, it's like he's no longer playing soccer with his friends, he hasn't left the house, he's cut off all contact with his friends, then that is a sure sign that that guy is probably suffering from a mental disorder, because he's showing a clear level of dysfunction. Dysfunction being the opposite of the word function, okay? Not functioning normally in life, according to how you normally functioned, is a clear sign of a mental disorder. The next level of a mental disorder is impairment. And impairment is about, impairment refers to a person's ability to act independently, to basically do things by themselves, to do things on their own. If you've got someone in a case study who isn't even able to, get out of bed, if they're not even able to go to work, they can't even muster up the motivation to go down to the shops to get some bread or to get some milk. They have to ask other people to do that for them. That could be a sure sign that that person also has a mental disorder, also accompanied by other symptoms like stress or anxiety and stuff. So remember, the two main things you're looking for when you're trying to determine from a case study whether a person actually has a mental disorder, whether that be specific phobia or any other kind of general mental disorder, we're looking for two main signs, and the main signs are impairment and dysfunction. Now, in chapter 11, we looked at a memory tip we called iPad, okay, to remember this. And iPad was this idea that obviously all mental disorders are characterized by some level of dysfunction and some level of impairment. So the I in iPad was for impairment. And then you've got other things in between as well. But these are the two kind of main signs. So this is impairment. And then you've got the A is for atypical behavior, and the P is for like problems with coping with stress and all that kind of stuff. So essentially, when we're looking at, sorry, why am I going to write this? I'll write it up here. So P is for problems of dealing with stress or personal distress, and then A is for atypical. So these are the four indicators or the four characteristics that you would use as a kind of theoretical checklist or conceptual checklist. When you're going through a case study, try to determine, does the person or do the people in this case study show impairment? Do they show personal distress? Okay, do they show high levels of grief? Do they show grief that is, getting them down for years? Or do they show resilience? Okay, atypical thoughts, feelings, and behavior. Do they show atypical thoughts, feelings, and behavior? And lastly, do they show dysfunction? So these are the four indicators we're looking at when we're looking at, does a person have a specific phobia, or does a person have any other type of mental disorder? Okay, because you could be asked specifically for specific phobias, or you could be asked in general for an actual mental disorder. Okay, so next topic, let me see what else we have here. So can phobias and things where people are filled with disgust, like can that be a phobia where we do testings? People who have specific phobias, they do show a high level of negative attitudes and negative emotions towards their phobic stimulus. So if I'm scared of seagulls, yes, I would find seagulls disgusting. I would find seagulls to be very abhorrent. But I wouldn't say that just because, like for example, there are general things that all humans find disgusting, like, what can we think of, like garbage or poo or those kinds of things. So essentially, even though we're disgusted by those things, we don't fear those things. But if you had like a traumatic encounter or multiple traumatic encounters where, maybe you were going through the trash and you saw a bunch of rats kind of in your garbage bin or something like that, then you might actually start to develop a phobia of garbage, okay? Not because of the garbage itself, but because of the association of looking into your garbage and seeing a bunch of rats maybe I don't know, maybe like eating your garbage up or something like that. But no, we can't actually develop a phobia just from mere disgust of a particular thing. It has to be some kind of a repeated association there between the said disgusting thing and the negative experience that would normally cause fear in someone. Okay, so that is that, and we had to, the next topic that we had to go through was psychological intervention. So I'm just going to skip forward a few slides. And also, those of you who still haven't given me a topic, I'm hoping you're okay with the topics, but if there is a topic that you are confused about, please put that in the chat box. And then we can go through that today. So today's all about clarifying your doubts from chapters 11, 13, and 14. So let me know. I'm happy to go through any of the topics from those chapters again today, because we might not get time later on to do this again. Obviously, if we have to, we will try to fit it in somewhere, but I really want to focus on practice questions from here on out. So if we can try to get the content side of things done, content clarifications done by today, then we can have more time to do practice questions. Alrighty, so psychological interventions was the next thing that we kind of had to clarify. So when we talk about psychological evidence-based interventions, we're talking about the psychological related treatments for specific phobia. So what are the ways in which we would manage or treat or address specific phobia from a psychological point of view? And remember, psychological point of view or any psychological perspective or psychological treatment is all about focusing on how we can address the thoughts and the feelings related to specific phobias. So we're just going to go through those now. Question, okay, what week is this one? We have holiday class as well. Yeah, so this is obviously the last week of school. So next week we will be having holiday classes, okay? The holiday classes don't follow a special timetable as far as I know, because our holiday classes will just be running in the same time as our normal class. So your holiday class next week will be Wednesday at 11 o'clock and Thursday at 11 o'clock, which is the same time as we'd normally run it. Now, what we're going to be doing in those holiday classes is we are going to be going through the answers to a practice SAC, and I'm going to be giving you that practice SAC on Friday afternoon. Okay, there is already another practice SAC just for chapter 11 on the school box, which I did talk about at the beginning of the lesson. So you can find that on the second post of the social stream. It's a chapter 11 only practice test, and I want you guys to do that practice test, get it done by this Friday, because this Friday online lesson, we are going to go through the answers to that practice test. And after we finish going through the answers to that chapter 11 practice test, I'm going to upload an actual practice SAC for all the chapters for 11, 13, and 14. And you're going to do that in the few days you have before next week's online class. And probably on Thursday online class, just to give you a little bit more time, we will discuss the answers to that properly. And on the Wednesday, which is the day before, we will try to just clarify any other doubts you have, or any other questions. So that's the plan for next week, hopefully. Okay, so yeah, cognitive behavioral therapy is the first psychological intervention. So when we're talking about cognitive behavioral therapy, remember it's about addressing your thoughts and your feelings, and hopefully in the hope that you can also address your behavior. So cognitive behavioral therapy works on the idea that if we can address our negative thoughts about the phobic stimulus and address our negative feelings about the phobic stimulus, we can then change the way that we act, and we can change our behavior as well with reference to how we act around our phobic stimulus. So negative automatic thoughts are generally seen in people who have specific phobias. And this is basically talking about, like, if I've got a phobia of spiders and I walk into a room and I see a piece of thread like on the floor somewhere, or I see like a little, I see a bit of dust or something, I start panicking straight away thinking, oh my God, is that a spider? Oh my God, is it going to come and kill me? Oh my God, how fast is it going to run? Oh my God, can I outrun it? Blah, blah, blah. So all these negative automatic thoughts automatically kind of immediately popping into the person's mind are very prevalent in people who have specific phobias. And so what we try to do with cognitive behavioral therapy is we try to first of all undo those automatic negative thoughts, try to get rid of them. And in doing that, we're also trying to get the person who has specific phobia to have a more positive attitude towards spiders or towards whatever phobic stimulus they are suffering from. So we'll be like, okay, I want you to, not feel disgusted towards spiders. I want you to see that they are a living organism like any other living organism. I want you to understand that spiders are not as scared, that you should not be so scared of spiders. They're probably more scared of you. So trying to get their feeling into a more positive state of mind. And in doing so, we want to try to address the actions as well. So we're addressing the thoughts, which affects the feelings, which will hopefully affect the behaviors. What do we want to see in terms of the behavior? Remember how we talked about avoidance behavior and how people with specific phobia will do anything to avoid the phobic stimulus? And yeah, that's essentially what we want to do. We want to completely eliminate the appearance of that avoidance behavior. And we don't want the patient to just run away from their problems. We want them to actually confront and to stand up to that phobic stimulus and to show courage and to show bravery rather than just running away from it at every instance or opportunity. Okay, so that's what cognitive behavioral therapy is. It combines the power of cognitive transformation, which is transforming your thoughts and your feelings, as well as behavioral transformation, which is changing your actions or your behaviors. Okay, with reference to the specific phobia. Okay, I've just literally gone through this. Yeah, so the cognitive component of CBT is changing that person's irrational or negative way of thinking. So rather than them standing like 3 kilometers away from a piece of thread, thinking that it's a spider, we're getting them to think in a more realistic and more reasonable way. Okay, that's what rational means. When we say someone is thinking rationally, it means that they're thinking in a reasonable, realistic way. When we say that a patient with specific phobia, though, is thinking irrationally, that means that they are thinking in a unreasonable, unrealistic, and illogical way, a way that just doesn't make sense to anyone but themselves. Okay, and because of the mental disorder they have, we can't really blame them. Phobias kind of set up people to think in irrational ways as well. Okay, so that's basically the cognitive component, and the behavioral component, like we said, it's about getting rid of avoidance behaviors. And in the journey or in the pathway that we take to get rid of those avoidance behaviors, sometimes we have to implement other behaviors or other kinds of strategies as well. So in order to kind of relax ourselves and calm ourselves, we might have to engage in some breathing retraining where we change up our breathing patterns to breathe in a more calm way. We might have to engage in things like yoga or meditation to actually relieve the stress out of our muscles and things like that. So along with just trying to get rid of those avoidance behaviors, sometimes we have to use additional behavioral strategies to actually support our efforts. Okay, so that's essentially the behavioral component of CBT. The next psychological, and the limitations are, generally for all these treatments, the limitations are more or less the same. For specific phobias, we have to remember that some specific phobias do have a traumatic basis where the person did go through some kind of trauma or some kind of, repeated kind of trauma or negative experience. And so even though it's easy for us to say, oh yeah, the way you think affects the way you feel and that affects the way you behave, blah, 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 it's actually very difficult to practically undo behaviors and undo those negative automatic thoughts and feelings in patients with specific phobia, simply because those behaviors are so entrenched. And remember, we said avoidance behaviors, even though they're something we don't want to see, avoidance behaviors generally make the specific phobia patient very happy. They make them feel a sense of relief. They make them say, you know what, phew, I was able to avoid going to the St. Kilda beach and avoid seeing seagulls today. So getting this person out of a state where they're like, phew, I'm so relieved I was able to avoid, into a state where they're like, oh my God, I have to go to the St. Kilda beach, blah, blah, blah. It's very hard to do that, okay? Because you're getting them out of their comfort zone. And patients, not just patients, no one likes to go out of their comfort zone that easily. So those are the limitations of CBT. So systematic desensitization is the second psychological intervention that we needed to go through today to clarify. So systematic desensitization is the systematic meaning step by step. So I'll just write that down. Okay, so the step-by-step desensitization. When we say someone is desensitized to something, okay, if you ever watch like a crime show and, the person who's working at the morgue, they just see a dead body and they're not even fazed by it. They're desensitized to it. They're no longer affected by it because they've just been exposed to it so much. So that's what we're trying to do here. We're trying to systematically desensitize. That is, desensitize the person to their phobic stimulus in a step-by-step manner. So what that means is that progressively, step by step, little by little, we expose the patient to stimuli that are very similar to the actual phobic stimulus that they're scared of. And in this case, when we say CS, we're basically referring to our phobic stimulus, okay? So it should be PS as well. They're the same thing. So increasingly similar stimuli to the actual phobic stimulus to gradually desensitize them, okay? So they're no longer, when they see that phobic stimulus eventually, if this treatment goes successfully and everything is good, when they eventually see that phobic stimulus, they are no longer scared by it. They no longer show the phobic response. That is the kind of key, oh my God, where am I drawing? Okay, that is the basically key idea behind behind systematic desensitization, that eventually when this person is exposed to the phobic stimulus after the treatment is done, they will no longer be scared of this particular phobic stimulus. Okay, so obviously the first step of systematic desensitization is creating a fear hierarchy. The second step is teaching relaxation techniques. So that's the first step. Or, you know, it doesn't really matter the order. You could even teach them relaxation techniques first and then begin the fear hierarchy. There's no strict order to it. And then obviously the third step is making them go through each of the tasks in the fear hierarchy. And the fourth step is actually exposing them to the phobic stimulus to test, does this person still show the phobic fear response, or are they actually just over it? Have they recovered? Okay, so just showing you the fear hierarchy. So yeah, this is the fear hierarchy. So you can see that as we go from tasks that are lower to higher, you can see that it gets more and more scary for the patient who has a phobia of dogs. So you start with really kind of easy tasks like looking at pictures of small and large dogs, which shouldn't induce too much fear in a person with that specific phobia of dogs. And as you're moving up, it's getting more and more intense. You're actually starting to get closer and closer to being exposed to a dog. Okay, so for example, petting a large dog is very different from letting more than one large dog lick your face. Okay, so that's obviously the highest fear level for this patient, 90 out of 100. So this is the task that after we finish with this systematic desensitization to test whether that person is actually over their phobia of dogs, we put them through the task. We get several large dogs to run up to them and lick their face. And if that person doesn't show a fear response, then we can say that, yep, our systematic desensitization process was a success and this person has recovered from their specific phobia. So again, it's a process. This isn't something that we can just finish in a week or a month. For some patients, you know, the progress it's not like linear, like it goes up, it goes down. Sometimes you might reach up to this, you might almost reach the end and then you have a traumatic encounter with a dog in the neighborhood when you're walking through the park the next day and you're all the way back down to square one. So phobias are very complex. They're not as easy to recover from as we think, but systematic desensitization is a way that we can ease the patients into getting over their phobias. And obviously the limitations for systematic desensitization are, number one, it is a very time-consuming process, as we talked about. A lot of patients don't want to commit to that. And for a lot of patients, it's not as easy. Recovery is not as easy, okay? So particularly if it is a phobia that they've had from a very young age or a phobia that continues to kind of exist. So if you live in the same neighborhood as you did when you were a child and you've got the same kind of, you know, like very kind of feral or violent dogs living in your neighborhood, you don't really get any relief from that. And you kind of like, you feel scared to leave your house to go for a walk because you know that those dogs are still there. So that's basically some of the limitations of systematic desensitization. So I think I mentioned this when we originally did this topic, but honestly, just know at least one limitation. Again, like the limitations are really like pretty straightforward, almost the same for all of them. Okay, most of these interventions do require some kind of a time commitment, do require some kind of patient motivation. If the patient doesn't believe in the treatment and believe in their ability to recover, they'll never recover. So it's very dependent on the actual patient motivation and stuff. Okay, so let me go back to the chat box and see what other topics we have. Can't we grow out of fears? Yes, so you can grow out of fears, but remember, fears are not the same as specific phobias. So specific phobias are different from your usual fears in the sense that specific phobias are clinically diagnosed. So specific phobias lead to some level of dysfunction, lead to some level of impairment, okay? They lead to a very high level of personal distress, and you're almost always like, your brain is almost always in overdrive thinking about, you know, you can't even leave the house, you can't even go to the grocery store, you can't even put your bins out because you're worried that you might encounter that phobic stimulus. You know, whether it be a dog or whether it be a car or whether it be a bird, okay? You're just worried all the time. Fears are a little bit different. People can grow out of fears. A lot of the time when children are young, they fear, sometimes they fear things that are real, sometimes they fear things that are imagined. So a lot of children have fears of things like monsters, but obviously they grow out of that. A lot of children have fears of snakes, but if they were to go on a school excursion or if there was an incursion where, you know, a trainer has brought a snake in, it's not like they're going to run out of the class. They'll just sit from a distance and kind of listen to what the guy has to say about the snake. Phobias are different. If you're a person with a specific phobia participating in a primary school incursion, the minute that you see that guy bring the cage in, the snake's not even out of the cage yet, it's not even in the guy's hands, you are going to start sweating, you're going to start hyperventilating, you might have a panic attack, you might literally just run out of the class. So that's the difference between a fear and a specific phobia. Okay, so with me, like I have a kind of low-key fear of, you know, like mice and like, I don't know, animals that move really, really quickly and like they're hard to control. I don't know why I have that fear, but that's just a simple fear. It's not a full-blown phobia. So that means that obviously I wouldn't want to see that in front of me, but like I'm not scared of mice. In fact, it's kind of like contradictory because my laptop case is like Mickey Mouse and I love Mickey Mouse and I love that. I love those characters. So it doesn't even make sense at the end of the day. If I'm a person with specific phobia though, I would not even be able to look at a cartoon character. I wouldn't even be able to look at Mickey Mouse. I'd actually get scared just looking at Mickey or Minnie Mouse. Okay, so it can be that bad for people with specific phobias. So remember the difference between a normal fear, which is something that can just be from a one-time experience, which isn't really that intense, compared to an actual specific phobia, which is a full-blown fear where it's actually impacting your ability to function normally and to live as a normal person, go to school, go to work, interact normally with those around you. So that's the difference between the two. Alrighty, so what other topics do you guys have for me to explain or to re-explain? I don't see any others in the chat box. Okay, all right, so I think if I'm assuming that you guys are all good because I don't see any other topics in the chat box. So before you go, I'm just going to, first of all, I'll just stop the recording here. Before I stop the recording, sorry, I'll just tell you guys that if there is a topic that you come across and you want me to re-explain it, just let me know at the beginning of tomorrow's lesson. I'm happy to obviously explain that again because today you might not realize that there's something that you find confusing, but maybe when you're going through the PowerPoints today or later on, you might realize that there's a topic you want to have re-explained. So please go through that. The worst thing would be that there's a topic that you don't know and you didn't ask me to re-explain it and you're still confused about it and it comes up on the SAC or it comes up on the exam. So just make sure that you do ask me to clarify any topics that you are still confused about. So now I will stop the recording here.